Kia ora koutou. I'll start our hui with karakia. Tēnei te ara o Ranganui, e tū aki e nei. Tēnei te ara o Papatuanuku, e tātoko nei. Tēnei te ara o Rangi Raua Kaupapa, e tātoko nei. Kia raro te tapu wai o tānei ki raro. Tēnei te pō, no mai te ao. Karangatia te ao I piri, karangatia ko tānei I piri I tata. Whakamaua kia tina hui e tāhiki e. Nai mai, haere mai, and welcome to the third webinar in our crisis response series. For this webinar, we're going to be focusing on the findings of our recently published monitoring report, Urupere Morere, Crisis Responses. It is my absolute pleasure to introduce Barbara Disley, who is a well-recognised leader in mental health and addiction and has been a strong advocate for many years to improve outcomes for those with mental health and addiction issues. We're privileged to have Barbara on the board of Te Hiringa Mahara and have her chairing our session today. Barbara's previous roles include Director of Mental Health Foundation, Executive Chair, Initial Mental Health Commission, Deputy Chair, Executive Ministry of Education, Chief Executive Emerge Aotearoa, and she's currently the Deputy Chair of Te Hiringa Mahara, Mental Health and Wellbeing Commission. She's Chair of the Global Leadership Exchange, and she's a member of the Mental Health Assurance Group. So kia ora, and over to you, Barbara.
Ngā mihi nui, tēnā koutou, tēnā koutou. Ko Barbara Disley, tuku ingoa, and thank you very much, Sonya, for that warm welcome. We're really pleased to have you join us for the kōrero today. The focus of this webinar is on crisis response around and across Aotearoa, and how that can be improved. We will be building on our findings from our crisis response monitoring report, which many of you will have already had a look at. So just a few little housekeeping things before we get into the whole thing. There is a Q&A function. We will be having a question session at the end. So there's a Q&A function that works, and you can put your questions in there and then they'll be shot through to everybody. There is also a chat function, and if you go into the chat function, your name will be visible, and just letting you know that for privacy if you don't want it to be. We won't be sharing the chat record with anybody, so we will keep that really tight. But we'll also ask you not to screenshot anything, because that takes it out of that arena and takes away the control. We will have the webinar available for anybody. It will be on YouTube, and we can send through the link, and we'll also send through the slides if you want those. So we're really keen to get feedback. We're really keen to get comments from everybody. So I'll just tell you a little bit about Te Hiringa Mahara. As you know, we are the Mental Health and Wellbeing Commission, and we have a mandate to monitor mental health and addiction services across Aotearoa. We're an independent Crown entity, and we're committed to being grounded in Te Tiriti o Waitangi, and also to amplifying the voices of lived experience. So through our monitoring work, we shine a light on things that are working well as things that are not working so well, to try and drive improvement. So I'll just let you know who our speakers are today. You will know most of them. They've been around for a little while now, so on this topic. So we've got Sonya, who will be providing an overview of the report and the findings of that report. Kerri Butler, who brings a very strong and wonderful experience led perspective And so Kerri's going to be talking to you about that. And Leeanne Fisher, who is the National Chief Mental Health and Addictions with Hauora Health New Zealand. And Leeanne will be speaking to you again on operations and what's happening in practice. So that's where we're at. I won't spend a lot of time introducing people because it's much better for you to hear from them and get their response. So I will now hand over to Sonya. Sonya is of Ngāpuhi, Croatian, Irish and English descent. She lives in Tamaki Makaurau, and she's got a strong background in our mental health sector, having worked in many places all over it, and brings that perspective to her work for Te Hiringa Mahara as our Director of Mental Health and Addiction Sector Leadership. Over to you, Sonya.
Kia ora koutou. Ko Sonya Russell Tukawingwa, and thank you very much, Barbara, for that warm welcome. I'm going to be talking about our recent monitoring report, Urupare Mōrere, the Crisis Responses Monitoring Report, and taking you through our findings, the changes that we want to see, and recommendations. So people in their whānau have consistently called for better responses when reaching out to mental health and addiction services, particularly in times of crisis. As part of our monitoring role, we monitored crisis responses over the last 5 years, drawing on the experience of people both working in and using crisis response services. And we really wanted to understand what people's experiences were like, what the evidence says, what the pathways look like, and how these have changed over the last 5 years. And this helped us to start to define what a good crisis response system could look like for Aotearoa New Zealand. But I do want to say that this work is not just about reports and publications. It's about how we work together to improve our system and ensure that the voices of lived experience and their whānau are amplified and contribute to changing our system for the better. And so that's why we led a range of activities throughout 2025, including a series of webinars looking at international approaches through a literature scan, using a pathways visualisation tool, and presenting our findings at Hauora Hinengaro He Aotearoa on the 5th of November. So a key question to ask is, what is crisis? So experiences of crisis are often at a time of intense distress or disruption in thoughts, feelings and behaviour that significantly affects people's lives and those around them. From a lived experience perspective, crises are deeply personal, and people often describe crisis experiences as deeply connected to trauma. So we worked hard with our reference group to help to define what do we mean by crisis responses for the purposes of this report. And this is our definition. They're forms of urgent support assessment or intervention for people experiencing a crisis event that requires additional support to that provided in primary care or planned specialist care. So what did we find? Well, we found that crisis response pathways are hard to navigate, they're fragmented, they're patchy, and there's wide variation across the country. Many people are not getting the help that they need, particularly Māori and young people and those living rurally. Around 35,000 people had a crisis activity in 2024, and that's about 100 people a day. Over 50% of those people reaching out via crisis phone lines, and people are waiting longer to speak to someone than they were 5 years ago. Wait times have more than doubled, and in the last year, the rate of abandoned and unanswered calls has increased by 50%. Compared to 5 years ago, there's a higher proportion of calls that are urgent, and that's gone from 20% to 27%, and more people have called police for a mental health related issue, but the number of attendances has remained stable. Slightly more people have called for an ambulance for mental health related issues. The other key finding was that the system's under pressure, and through this report and our previous monitoring, we heard quite a lot about frustrations that people in their whānau face when they're trying to seek help. Over the last 5 years, we've seen an increase in call wait times, treatment days, complexity scores, and length of stay in inpatient care, all signs that the system is at capacity. Combine this with ongoing workforce challenges, and what we're seeing is a system under pressure. This next quote really captures a lot of the difficulties that many whānau are facing. Access was very difficult. Many police phone calls, hospital visits, only to be told he did not fit the criteria. Lots of meetings just to get him into a centre. This next slide really just shows that we've still got some real issues in terms of Māori and young people, a higher proportion of urgent calls for both those population groups. Rangatahi and young people aged under 25 have the highest rate of urgent calls, and over 30% of those with a crisis activity were under 25. They're also accessing ED at a higher rate, and they make up double the rate of ambulance mental health incidents. We continue to see inequitable outcomes for Māori. Of all the people with a crisis activity, over 32% were Māori, and they have the highest proportion of urgent contacts, as you can see here, and represent a higher proportion of mental health-related ED presentations. Of concern is the finding that Māori make up over half of the people who've had a crisis activity in a police setting, and that's what you see in this next slide. So while we've seen that an overall decrease in crisis activities in police settings, so we're talking predominantly about police cells, Māori still represent over half of all the assessments happening in police cells, and this was 1,800 Māori compared to 1,600 non-Māori for the last year. Health systems around the world are working to improve crisis responses and face many of the same issues that we face here in Aotearoa. Evidence shows that when crisis responses are embedded within a cohesive system-wide framework, they produce better outcomes. But we do see some strengths in Aotearoa models, particularly in relation to relational, whānau-led and culturally grounded approach. So we've got some good services here. We just need to connect them into a national system. So the changes that we want to see are a well-designed, coordinated national system across Aotearoa New Zealand. At the moment, we have a collection of services rather than an overarching national framework, but we need to build on what's already working well and scale these up. Kaupapa Māori and peer-led acute alternatives have proved their value, but they're only available in some areas. We need to increase the range of options. We need 24-hour crisis, 24/7 crisis support, and we need peer-led and community-based options for those. And we also need to be meeting the needs of those experiencing substance use crises. We need person and whānau-centred crisis responses that are easy to navigate and people know where they can get help. They need to get the right response when they need it, and they need to have access to safe and welcoming options. And we do want to see less mental health assessments occurring in police cells. We've made 2 recommendations in our report. Firstly, that Health NZ develops a nationally cohesive networked crisis system by 2027, 30 June 2027, needs to include a range of options, needs to be led by lived experience, needs to embed peer support, and needs to ensure timely and compassionate responses, as well as safe and welcoming places to go. We welcome the recent announcement of 61.6 million, and we do acknowledge the work underway to increase access to peers in ED, acute alternatives, crisis cafes, and co-response teams. But we need to keep moving forward through sustained leadership and cross-party support. Our second recommendation is about some shorter-term actions. We need nationwide access to 24/7 phone-based crisis support. We need clear, consistent pathways from primary care, and we need to be evaluating the impacts and the outcomes of the services that we're embedding. Before I finish, I do want to acknowledge all the people who generously shared their expertise, their experience, their knowledge, and their insights with us for this report. I also want to thank the team at Te Hiringa Mahara, who worked tirelessly on this report, and particularly Kerri Butler. We couldn't have done it without you. And on that note, I'll hand over to Kerri. Kia ora.
Tēnā koutou katoa, ko ai au I te taho tōku pāpā, ko poki haua, me poki hui ana maunga, ko tau kaho ai tāua, ko ngā toki mata whoro te waka, ko ngā pui me Ngāti Parau ngā iwi, ko Kerri Butler tōku ingoa. Kia ora, Sonya. Yeah, I've actually changed my presentation around a bit from when we did the conference, so I'll probably jumble all over the space now and be a little bit nervous about how I roll into this. But first and foremost, I do want to start by acknowledging the many people in whānau across Aotearoa who are represented in the data of the Crisis Monitoring Report. Each and every one of them in their whānau will have a unique story, and I am one of the few represented in the data who experienced crisis between 20 to 2024 that has the opportunity to speak directly into the conversation here today about what a good crisis system looks like. Therefore, I also acknowledge the privilege I have that my nanny and many of the people I have journeyed with through the system over more than 3 decades do not have. When I think back over my 30 years plus that I've intermittently accessed mental health and addiction services, in reading and analysing all of my available clinical notes last year whilst writing my dissertation, I can say that there is no one time that my whānau and I experienced the ideal pathway from crisis to healing. However, there are many components of practices I've experienced across some of my admissions that collectively highlight what a good crisis system looks like. And for some reason, I can't click on the slides. So can someone please do next slide? I've looked for the button, it's not there. Prior to my admissions in 2020, I hadn't been admitted to an inpatient setting since 2008. And what I recall, though, from prior to 2008 was that the system was less fragmented, more cohesive, and it was a lot easier to navigate and to get the right support that I needed to prevent inpatient admissions. When we talk about prevention and early intervention, the emphasis also needs to be on facilitating timely and easy access to the right support to reduce any of our crises, to reduce the effects of the crisis increasing or escalating. There needs to be a focus on shifting the non-urgent response of doing very little or doing nothing till resources are available to one of opportunity to intervene early, as this could have prevented, in my case, could have prevented some of the admissions I experienced in 2020. Similarly, there needs to be a shift from coercion and criteria to one of connection, collaboration, coordination, and compassion to prevent crisis from escalating, particularly in situations where 24/7 support may be needed for a short period of time. The options must include kaupapa Māori responses, lived experience-led responses, and responses that meet the needs of our rangatahi and young people and for people experiencing substance use crisis. One of the key things I recall in some of my early admissions was actually having a relationship with the services. The crisis and the community teams in the region that I lived were well connected and well coordinated so that if I rang up, they knew who to speak to and I could access support quite easily. They knew my whānau. They would ask me how my girls were, how my parents were, so they knew who I was, and I was seen within the services. They also knew what resources I had available to me, which was really important because when they were navigating support, it wasn't based on the criteria of what I was presenting as. It was based on what can my whānau do to support, what do we all need for me to be able to stay out of hospital. There is a big difference, and I do hear this a lot, of being able to access someone's notes to actually knowing them. And I think we have to be a little bit careful to saying, let's all have access to everyone's notes, because some of my notes read a little bit like a naughty school card. And I don't particularly want everyone to have access to my notes, but get to know me and get to know my whānau and the dynamics of my whānau. That's what's important to me. One of the key things is once a connection is made to the services, it becomes a very narrow, linear, one-size-fits-all pathway for many of us. If anything, during these times, it's when we need greater access to more options. It's great to see an increase in peer-led options for when people are experiencing crisis, such as crisis cafes. And we need to make sure that these don't become an either-or option, but instead one that has clinical and cultural support readily available to people in their whānau. I want to kind of take a moment to just speak a little bit about whānau too. They are not a KPI box, KPI tick box, and too often they are treated like one. I have seen both my own whānau as well as supporting other whānau, the pressure the system spill out onto them, whereby there is an expectation for them to manage distress way beyond their capability and capacity. It's like the criteria shifts up a few more notches when there is a loving family alongside to support increasing and exacerbating distress. And this is something we really have to address. Whakawhanaungatanga is so important when we connect to services. Taking the time with us and our whānau to understand what is happening, the impact it is having on us all, what is needed, the dynamics of the whānau, and also what is not needed or can have a detrimental impact on us or our relationship. Some of my own experience of support, oh, hang on, I'm going to go back because you'll be reading that while I'm trying to talk. Some of my own experience of getting the right support in the past include community teams working with me for at least a year post-inpatient admission to get medication right. In 2008, I also had access to a psychologist to work with through the cumulative trauma I'd experienced in the system. When I was 6 months pregnant, they actually brought in, so I didn't have to go back into an inpatient unit. They brought in a community team and I was able to access 24/7 support respite within my home so I could still be a mama to my daughters. See, I've told you my notes were a little bit naff here. With the inequitable rates of Māori in specialist services and inpatient settings, cultural assessments and culturally grounded crisis response pathways must guide, inform and underpin the decisions that are made about the support we receive and the services that we establish. This is all over the place. The triage and assessment point is like the crossroads, and it is at this point where the decisions the system makes can have a huge impact on our lives and those of our whānau. It isn't just down to staff doing or being better, which sadly seems to often be the approach to squeeze staff more and more. We need to ensure that we have the right infrastructure, particularly for the lived experience workforces that are popping up. And the system has to actually make sure that staff have access to training, options and resources that mean they can respond earlier and facilitate support and care that just isn't straight through to an inpatient setting or onto the whānau. These are some of the really key things through triage that are written up here, and I'm hoping that you've all kind of read that as I've been clicking through the slides here. And that's, key is around identifying those cultural needs, trauma responsive approaches, and that risk assessments aren't just on the risk that we may present, but the risk to these other things that are part of who we are as well. And on to the final slide here. In my recent experiences as both tangata whaiora and whānau, the crisis response pathways have become very transactional and a bit like a conveyor belt, with a focus on symptoms and medication. For too many of us, our experiences have also involved unnecessary police intervention. It is great to see an increase in acute alternatives, but the increase in these services must also make sure that they are designed with the right people and include Māori and lived experience. It is and I think of one up here in the north, Rarangatahi, where their services integrated with clinical services to provide early intervention, as well as home-based treatment support when people are discharged. One of the key things I think about in that service is that they ask people if they want them involved, irrespective of whether they're under the Mental Health Act. That's a huge shift to be able to gain consent and enable that exercising of tino rangatiratanga. We do need to address the current power imbalances so that both mātauranga Māori and lived experience knowledge are equally valued and vital to that of clinical expertise, as this is ultimately what will shift the system from transactional and traumatising to a system that is fit for purpose and has options and approaches available to us all that can contribute to healing and well-being. I'm really mindful of time here as well, so I'm just going to skip to the last slide here.
You've got time.
Oh, have I?
Mm-hmm.
Okay. Thanks, Barbara. Whoops. So whilst individuals and individual clinicians and people have been instrumental in my own journey and made a huge difference, it's a bit of a hit and miss lottery draw that we have little control over when we are in services. The focus on healing must begin from the moment we reach out for support. One of the key things in here is around this stuff is shifting from that system defined recovery to you've recovered from the episode to actually focus on that healing and well-being. And when I think of some of the things that worked for me in discharge, again, were access to any psychological support that I may have needed, being able to sit down and do some of that psychoeducation with psychiatrists about the medication, understanding their purpose, when to use them, and having things like a rescue remedy and knowing what its purpose was in there. But the key thing was that opportunity to build a relationship with the services and connections to wellbeing supports or holistic pathways to healing. These are things that we need to emphasise. And just in closing, I'm just going to close with a whakatauki here as well. No, I'm not. We've come back to the whole screen. So I won't close with a whakatauki because I don't have it written with me on my bit of paper. Nō reira, tēnā koutou, tēnā koutou, tēnā tātou katoa.
Kia ora, and thank you, Kerri, for that. Just as Kerri has been very involved in all this work, and I really want to acknowledge that, Kerri, for you and the impact it's had on really the richness that this piece of work has been able to end up with. I want to acknowledge Leeanne Fisher, who has also been extensively involved in this piece of work. And thank you, Leeanne, for your input into this work. So Leeanne is from Health New Zealand, joining us from there. She is the National Chief Mental Health and Addictions for Health New Zealand and Te Whatu. And so I will hand over to you, Leeanne, and you can help us with your presentation and perspective on this.
Thank you, Barbara. Morena koutou katoa, ko Leeanne Fisher, takora, National Chief Mental Health and Addiction. What my title means is that I'm the most senior clinician in Health New Zealand in the national space. So I am a psychiatrist by background. I do have control over my size. It's working. Good. So I'll just go over again. What do we mean by that term crisis? And Sonya has given us the definition that the Commission used for their report. But it's just a reminder, really, that crisis happens along such a continuum that most personal distress is actually either self-managed, managed with the help of, family and friends, and not all that much human distress, which obviously happens in response to so many human and very kind of normal experiences that we have that are painful, loss, grief. So much of it does not happen in a kind of formal helping or kind of care system. And I think that, bodes well to kind of, remind ourselves of that. But it also means that when it comes to looking at formal systems responding to distress, that too has to be along a continuum, so that our responses are timed right, the right kind of response or intervention for the person at that particular point in time. So I've used the term here contingent and proportionate, and it just reminds us about we really need a menu, if you like, so that it's not as it has been for some decades, there might be a CAT response and inpatient unit response, and that's kind of all that there is. I think we have been busy in New Zealand over the last 20 years or so of building out some of the parts of the continuum, but where we find ourselves just now, even though we've become a national health service, is that we have the legacy issues of being variously, we'll call ourselves between 18 to 20 different districts that have built their own responses, and hence we come back to really, Sonya's provocation to us in the beginning, and what the Commission have asked Health New Zealand to do over the next couple of, next 1 year and then next couple of years, is really building out that continuum. I'm going to just say that this next point is kind of a given about, and of course when Sonya just spoke and also Kerri, they've just reminded us actually about the need at the moment is for the under 25 space, and also kind of Māori to be for any of our kind of new models, services, etc., to really be thinking about where are we not addressing adequately currently. And then the last, clicked too fast. the last point I just wanted to note there, for those that heard me speaking at the conference, I described the low risk paradox. So this is where people who go on to die by suicide, having had contact with our formal mental health services, most of those people have been assessed as being low risk. And so we know that our system is not, or this very categorical way of assessing someone's risk does not work. And so we must move as a system towards addressing what we know, because we know this. We can't say we don't know this. We must move towards a much more formulation-based way of assessing risk and get away from this categorization of low, medium, high. It's really quite meaningless. We must move towards formulation so that we're describing under what circumstances a person may be at risk of what, and what's going to influence it for both what both might make that situation more likely to happen, but what's also the most likely thing to be helpful. So that's really a kind of a paradigm shift, I think, that we need in our services. I'll just quickly click through these, the 3-point model here. The SAMHSA model, and it's been very much taken on by Health New Zealand because our minister is very keen on this as well, is the 3-point model about having someone to talk to, someone to respond, and a place to go. And so as we fill out the sort of continuum of care and of intervention, these are 3 points that we kind of are mapping services to. Sorry, there's a bit of a delay when you click. So the other thing, the other slide I thought I would still include here today is what is also known about principles and policy that should be behind services that we build, and that's still about being an advocate across the life course for what are the social determinants of mental illness in particular, but distress. We must ensure that our care is based on not necessarily the diagnosis, but on what is happening at that point of time. And this is where a staging model of mental illness could be considered. We want to make sure our frontline delivery of services is more than the very kind of biological, or I reluctantly say kind of medical kind of model, but that psychosocial interventions are also kind of on offer. So it's not only, are you going to be an inpatient or an outpatient, and are you going to have medications or not, that it's actually a broader suite of interventions. That it certainly embraces rights-based approaches, and that the lived experience is at the centre. And so, it's my provocation to the sector about, imagine when we're designing our services and delivering them about what if it was our brother, our son, our cousin, our aunt who was the person, calling. If we can think of it like that, what would we want for our own whānau? Then I think that kind of helps us to move forward in terms of the design and the delivery. So crisis intervention and the interventions need to be thought of as being on a continuum that is actually linked up. I think at the moment, and I think this is what the report really goes to the heart of, is that across the Whatu at the moment, it's still too patchy and kind of uneven about what's happening kind of where, and that, even if you move 10 k's down the road, if that's changing a district kind of geography, that you can't assume that the kind of service you got under one district would transfer to another. So this is the provocation to us all about improving, taking us from a collection of services actually into a system where things are linked up and it's more easy to navigate, certainly, than it is today. And so we can think of the continuum as happening along these kinds of steps. A lot of what Minister Ducey announced a month ago, a lot of that can be mapped to these steps. So we might talk about, for example, crisis cafes, even though it has the word crisis kind of, in it, that's really more a low intensity to maybe to moderate intensity, perhaps depending on the hours of operation of the cafes, because we've got different models around the country at the moment. But really we're building up that continuum so that even when we get to the high intensity and the bed-based care doesn't necessarily mean inpatient care. And hence we have with the two new peer-led acute alternatives, if that's going to be bed-based, but bed-based in the community, then what we can really see the difference there is that these are our kind of, three workforces, for want of a kind of a better word, or the three parts that need to all happen, but in different ratios along that continuum. So lived experience, our NGOs, and then the hospital and specialist services, or the much more clinical kind of services need to be working kind of together, but there's relatively different proportions as we sort of go along that level of step care. However, lived experience needs to be, throughout the continuum. I've also included in this step is if you like, the after a crisis. And if you were at the conference, you'll know I talked about a particular Australian model that I'm familiar with, which is the HOPE team, which is a great kind of acronym. And it's about a 3-month kind of program of work that is for those who end up presenting to emergency departments, don't need inpatient-based care, but they also don't need to be just sent back to GPs or to private practitioners. It's where we know that the risk after someone presents with a suicidal act remains high, and particularly the 3 months afterwards. So it's a wraparound support, including lived experience. It's one of the things that I hope that we get to sort of, build out this continuum as we're on this journey. And I'm just going to end with, even though I presented it there in a stepped way, I think this image from the conference was one of the ones that I got feedback on, about people wanting to see that, whether it's services, whether it's our Hauora, that services and people are kind of connected, and this kind of represents a system as opposed to what we kind of have currently. So that was it from me, Barbara. Thank you.
Great. And look, thank you, Leeanne. Certainly thank our 3 speakers today. We do have question time now. And so if you have questions, please put them into the Q&A chat, and they will be flicked through so that we can ask them of the appropriate people. So I do have a question here right at the beginning. So this one is, I'll just flag it. It's for Sonya and for Leeanne. So aren't you lucky to get the first one? And it's from, the question is from someone who's works across the OCD community and talks about the difficulty of accessing OCD specific care in the public health system. And it's common then for individuals and their families to seek psychiatric and psychological care in the private sector. So the question is, I'd like to hear your thoughts about the role and integration of the private sector in making referrals to crisis care and in longer-term support following a crisis care. It seems to me that the contribution of the private sector is currently invisible. So I'm wondering whether one of you would like to respond to that.
You're going to go, Leeanne. I was thinking there's kind of two parts to that question. So I think there's one part that probably fits more with you, Leeanne. But in terms of, I guess, that invisibility of the private sector, I was just going to say that the data that we looked at for the report was all referrals into specialist services. So that would include referrals coming in through the private sector. But in terms of our mandate or for monitoring, we are here to monitor the public sector. So we don't actually monitor the private sector, but in terms of that interface, that will be reflected in the data. But I think there's the other part to that question, Leeanne, more about what's available in terms of OCD. I'll hand over to you for that.
I might still have a go at the other bit. That's just to say, I mean, you're correct. I mean, it's a kind of statement of fact, isn't it? That I mean, there is a small, but I think growing private sector in New Zealand. And so, yes, in terms of kind of publicly available kind of data, it is kind of, it is hidden other than when it comes to that referral and perhaps kind of referral kind of out. I mean, I think there's probably a lot to be gained from things like shared care kind of models, but where it has to be pretty explicit between, I think, a private practitioner and the local public service that they're referring to about what is it that they're referring for. Is it that whole handover of care, or is it wanting to still maintain some relationship? So a lot of that will come down to kind of local relationships. And I imagine, despite telehealth, I imagine that, a lot of private practitioners still work, relatively in a kind of locality kind of based way where there's opportunity to build relationships, but probably it's one of those areas that I think will be emerging over the next couple of years as we see a growing privately kind of practicing workforce. So I think it's a kind of a watch this space as to how that's done. In terms of the other question about OCD, I mean, most of the referrals for any kind of OCD treatment in the public sector are likely to be happening more in that sort of more planned care kind of space where and I'm not sure who asked the question, but I was just in a conversation with a couple of people on Friday about this. I do think that there's a lot of work to be done about kind of refreshing the models of care and the types of treatments that are available. I am very, very aware that OCD can be a very, debilitating condition. And of course it starts so often in childhood and adolescence, which is my patch by background. So I'm just going to say to the person who asked that question, I'm aware that there's a lot to be done in this space, and that we don't have that right quite yet.
Great, thank you. There's a slightly similar question, and this one's for Sonya, which is around how can a new crisis service like Whakamatutu in Wellington deliver support aligned with this report's recommendations, gain traction and meaningful engagement from Te Whatuora before closing due to lack of funding. So effectively, we're talking about another service that sits outside of the core services.
Yeah, look, I mean, I'm not familiar with that service, but in terms of, I guess, talking to Health NZ, which I think is part of what the question is, I mean, I think pointing out, as you have, that it is aligned with our recommendations, I think is helpful. But I wonder, Leeanne, if that's something you can answer to in terms of having that conversation with Health NZ.
I'm aware that there's some conversations, if they haven't already happened, then they're happening, I think, this week with Whakamatutu. But yeah, so which I won't be involved with, but a couple of my colleagues are. So I think it's a very live conversation, and it comes down to, those funding kind of models. Yeah.
But also to the bigger question of having a bit more of a plan map of what should be on that map and what should be
what's out
nationally
there
available to people, and how that all fits together, which is part of the core, as I see it, of the recommendations that have been made. So, Sonya?
That's a good point, Barbara. I will just add to that. That is something that we found through our report, that there's lots of really good examples happening right across Aotearoa, and it is about, as you say, recognising those and scaling some of those up. So this might be a good example of that.
Yep, this one's for you as well, Sonya, and then there's one for Kerri coming up. So, the question is, a bold, visible and clear focus on the next 5 years. How will Te Hiringa Mahara particularly promote and advocate for lived experience and peer support, in particular promoting and supporting leadership and self-advocacy?
Yes, that's a good question. So look, there's a range of ways in which we advocate for growing the peer support workforce, and we have done through a number of our reports. We've been very clear in terms of our recommendation that we do expect to see peer-led acute alternatives and other options coming online as part of this national cohesive model, and we have seen the evidence both in Aotearoa and overseas about the importance of embedding and having lived experience-led approaches in terms of the planning, the design of that, but also those peer-led services as part of those range of options. We also have lived experience position statement, as people may be aware, and we are working on an implementation plan of that right at the moment, actually, and looking about what are the activities that we need to be doing in terms of advocating more strongly for that workforce. And we work quite closely with Hana Komatsu on that as well. So there's a range of activities that we're doing, but look, we're always open to hearing feedback and advice on where and how we can be leaning into those spaces more. So welcome there.
So we've got quite a few questions coming through, so we'll have to speed up. Kerri, this one's for you, and it's from someone who's saying, I have 8 years lived experience with my adult daughter experiencing severe mental health with many admissions, community support, etc. My biggest suggestion for whānau is that they be given an information package about what may be available to support them, e.g. Yellow Brick Road, respite, other resources. I have found this sadly lacking. So do you?
Yeah, look, I absolutely tautoko there. And, certainly from my own perspective, I've got 3 amazing daughters who were 17 to 22 in 2020, and they were put in some really challenging positions without having all the information. They were often brought in for what they describe as clinical meetings, and instead of being asked about things, they were told this is what's happening, which is a really challenging position to put kids in. And I can see sort of from my clinical notes, and then they were handed a pamphlet, almost like, there you go, we've done our whānau. But there actually needs to be those opportunities and spaces for whānau to have opportunities to share their own distress, not about talking about the person, but what is actually happening for me, but also giving them some education. And years ago in one of the units I was in, they used to often run a session every single night at 6:30 that were kind of psychoeducation spaces for whānau, for us, for whoever, to be able to come in and get that. And I think that's a vital key part. My kids were fortunate that my mum's a registered nurse, or was a registered nurse, and their dad had been through the system with me, that they actually supported them. But I know many whānau who don't have that. So yes, I absolutely agree. We need to do better for whānau. We need to also be investing in whānau advisors across the system. They've sadly been depleting. It's not an and or with lived experience in whānau, it's an and. And
Yes.
I think the system needs to stop doing that kind of, one resource or not. So
Great.
that was my political rant for the day.
That's fine. You're allowed one. Okay, so this one's for Leeanne and Sonya. It's about crisis cafes. Are there plans to set up multiple crisis cafes throughout New Zealand? And they have been growing, as I understand it.
Yeah, so let me just see if I can absolutely get the numbers. Sorry, I'm just busy looking at a document. With the announcement the Minister made a month or so ago, there will be 2 new crisis recovery cafes adding to the 6 already established, so that will make a total of 8. Obviously, that is not very many across the whole Whatu, but you can see that our minister is very much interested in investing across that whole continuum. So crisis cafes and peers in ED is the other place where the peer workforce in particular is, that's the peers in ED. So it's once you've already got the, who is it that you're encountering. So with the most recent announcement, that's of an additional 3 emergency departments will benefit from having peers. So that is in addition to the 8 that are already, 8 EDs that already have that workforce there.
Great.
Hopefully that answers that question.
Great. This one's for Kerri and or Leeanne from Kevin Harper, and it says it's about integration connection. Kerri has represented a lived experience perspective very well. Pat on the back for Kerri. One common theme changing minds hears from community engagement is that people's problems are complex and need sophisticated responses. Can we join up responses to reach beyond health services to be more supportive of a range of needs and contributing factors? So over to you, Kerri and Leeanne. So it's that broader base of needs as well as integrated health needs.
Yeah, kia ora, Kev. Look, absolutely. I mean, that's what the whānau order approach is, isn't it? It's all about actually that whole of connected of all of those things through there, and totally agree. And one of the things I have seen that is done well through the addiction and substance harm space with friends that have gone through is they do connect them up to it's about looking for all of those other things outside of there. And I think we do need to lean into more of that rather than it's just you're through, you're in, you're out. And that's what I talked about with the conveyor belt. Over to you, Leeanne, to add even more value. Or do better.
About that, but just to support that, that's I think what we would all like, but the but I'm going to say is that as human beings we're always prone to compartmentalizing, aren't we, and doing that silo thing of, and so Kevin, I mean, you'll well know, the range of sectors and ministries and departments and, services that it kind of takes to try and have a holistic kind of view. I know in the, child protection space, if I just think about that, because that's been my kind of background, that, I was one of the things I've often kind of said in that space is that a system can't replace a family, right? The kind of number of things that, parents and extended whānau think about when they're kind of raising a child can't be done by kind of a system. And so, in our kind of space, I think it's the importance of having, the Hauora and whānau kind of perspectives as advocates kind of alongside someone, is to be thinking about all the and we need help with this and that, and because someone suffering let's say with kind of mental illness that takes them out of the workforce, for example, and, the steps towards getting kind of income support and, paying the bills, all of those kinds of things. I think too often, because we can't, as doctors, nurses, social workers, psychologists don't have direct control over that. Sometimes it's too easy to kind of other it, and yet we can be powerful kind of advocates in that space. One, to remember if no one else is remembering it, but two, to try and support people getting access to, their entitlements, etc. So I think, Kevin, it's a good provocation to keep thinking about, the whole person in kind of their needs and what, not only what health's contribution can be, but how health can be thinking whole of system and whole of person as well.
Yep. There's a couple of questions here, so we do need to be quick on our answers, and I'll try and combine them. One is around, I noticed in the chat there is one about refugee community and access to crisis services and what happens after if you're a 9-to-5 service, not a crisis. And it's a similar question about rurality and after hours. So what is the plan for funding expanding after hours services to better meet community need? Sonya or Leeanne?
So I'll have a first go at that. So I think, I don't have a crisp answer for you, but I think that there's pieces of work that are being done about accessibility. Accessibility meaning everything from kind of languages to when someone perhaps has, communication difficulties, like our, deaf mental health kind of community, is thinking about having good quality information out there that's, easy or easier than it is now to navigate, so that people know where to go. I've seen news coming through about now I know that not everyone accesses after hours. It's not all done by Whakarongo, but if I kind of go to the range of things that agency is able to offer to people, they are continuously looking at how to make things better, more accessible. Last week there was some news about kind of an AI assisted tool that they're building to kind of help. So sorry, it doesn't go directly to your question, but I think we keep thinking about and what about, and so how would that person know where to go, for example, and then once they get into the system, it's then also about meeting a system that is able to be respectful and responsive to those persons' needs as well.
Okay, last question, and I'm going to combine two. One is about youth and young people. Are there plans for step-down live-in centres for young people like they have in Australia? And the second question related to a very specific population, and that came from Emma Gardner and from corrections, and it says, does the monitoring report include the number of people coming into corrections who are acutely unwell? What does recommendations in this area mean? And will prisons be able to access these crisis services outside forensic hours? So that's an interesting one. That one was for you, Leeanne and Sonya. So last question, and then we'll go to wrap up.
Okay, so I'll just very quickly talk to the rangatahi and youth question. I guess we are, as I talked about in my presentation, we are concerned about some of the trends that we're seeing for rangatahi and youth and longer wait times for services. And so we are doing a deep dive to really understand what's happening across services for rangatahi and youth. So we will be working on a report of a similar size to this one on crisis, looking specifically at rangatahi and youth and what are some of the service options that might work best for that population. So that's the first question. In terms of the corrections question, this was predominantly using primed data. So it's again about people being referred through to specialists. So if that referral source is coming from corrections, then yes, it's captured. But in terms of access to specialist services from forensic settings, that is definitely part of the continuum. And I don't know, Leeanne, whether you wanted to speak to that more specifically.
Emma, I'm thinking this belongs to one of our working groups. So Health New Zealand and Corrections are working a lot together at the moment. So I think it is a good question to go to probably the working group that I'm kind of on. I mean, there's nothing kind of stopping access, obviously. I mean, it's likely to be obviously a correction staff member who's ringing to kind of access assistance. And I believe that already kind of happens in terms of our ringing our telephone kind of crisis lines to get support, and then making kind of a joint decision about what is actually needed in that sort of after hours kind of space.
Yep.
Sorry,
And there's a couple of, sorry.
Oh, sorry, just one last comment on that. We did use a pathways visualization tool to pull some of this data, looking at primed data and pathways. So if there are very specific questions like that, do feel free to email us, and we might be able to dig deeper into the data to seek some answers.
Yep, and I can see in the webinar chat there's some great questions and comments and suggestions. So we will go through those and make sure that they're kept alive and run through for us. Okay, well, look, thank you everybody for joining with us. Thank you to our speakers. Thank you, Leeanne, for being supportive along the way, the journey, the 12 months, 18 months journey of this piece of work and the seminars. Likewise, Kerri, you've been very involved in this. Really, really value your input. And Sonya for steering this to its birthing, and now it's nurturing. And that's the big part now. How do we nurture, grow, and support what has come out of this report for change? So I will now thank you all, everybody who's been online. Thank you. And let's just hand over to Sonya to close with karakia.
Thanks, Barbara. Hauhihiri, haurarama, te aho I roti. O roto, marama I roto. Tēnei tipo, ko tipo ka iki. Nā tipo o inei kōrero. Ka mā te ariki, ka mā a tauira. Kia puta, ki te whaia, ki te ao marama. Hui te ora, hui te marama, hau mea, hui e tahiki e.
Okay. Kia ora. Thank you, everybody. Ka kite.
Ka kite.